I'm an R4 at the University of Colorado in Denver. We're going to open up our programming this afternoon by doing a career panel. We're very fortunate to be joined by 5 people who are all going to talk about their practice model that they're in, be it academic, private practice, or somewhere in the middle. And the idea behind this is they're all going to give a short introduction of kind of what their model looks like, what their story is. We're going to ask them to sit up here, and then the whole idea behind this is going to be that we want you to ask questions. This is a panel that's meant for your benefit, talking about the differences between these different models. So we're going to get started. Our first one is going to be our academic person, and this is Dr. Jonathan Chung. Dr. Chung is an associate professor at the University of Chicago, where he also serves as the section chief of thoracic imaging and interim vice chair for quality. Dr. Chung completed his training at the University of Washington and a fellowship at MGH in Boston before initially working at National Jewish in Denver. So I have to give him a little Colorado shout out there. So thanks, Dr. Chung.
So I don't have slides or anything. I'm just gonna talk at you guys. I am a little bit of a talker, so you guys might have to stop me, right? So that's my issue. And my residents will tell you that I am a talker. So I will say that I'm a convert. So when I went into residency, I thought 100% I'm gonna go into private practice, right? And so at the time, when people coming out of practice were making ungodly amounts of money, and so I heard about this kind of money, and I thought, boy, with that kind of money, imagine what I could do for my parents, for my kids, for my family, maybe even my kids' kids. And I was like, I could do a lot of good with that. So I was attracted to that. I was also attracted to just reading studies. I thought, radiologists read studies, and private practice, that's what you do. Most of your day is spent reading studies. And so after my first year of residency, though, my model sort of changed, right? The paradigm changed for me. There was this guy, Satoshi Minoshima, right, who is a big-time researcher. And so he gave this lecture on research, and those are usually the lectures that I hated the most, right? Because this dude's gonna come up here and he's just gonna talk about his research for an hour, and it's I just need to get on my iPad and play, right? Just gotta pretend like I'm actually taking notes, but I'm actually checking Facebook, right? So he comes up there and he starts talking. Before he starts talking about research, he actually puts up this slide, right? And he shows this slide of how being in academics, you can have more of a multiplicative effect on society, right? So as a radiologist, you interpret studies, you could save lives. You guys are all heroes, right? You save lives every day. But if you're in academics, you could train people how to save lives. So you have that multiplicative effect. My trainees, my residents, my fellows, that kind of thing. If you do awesome research, and so really, really good research, and so I'll tell you, good research and bad research take about the same effort. So if you're going to do research, do good research, right? Ask good questions, have good hypotheses. If you do good research, have good questions, and you actually figure things out, you can then disseminate that to the rest of the radiology community and have a positive effect there, right? And so we're talking maybe millions of lives affected. That's a lot more than you could affect just by yourself. And so my mind just went, I was like, wow, that's so amazing. And so I didn't go into medicine, and I doubt anyone here went to medicine because they just wanted a job, right? Because there's a lot of easier ways to make a buck. If you just want to make a lot of money, go into business, right? Make a lot more money. It's probably easier, or probably a lot less stressful. But you went to medicine because you want to make a difference, right? You went to medicine because on your deathbed, you wanted to be able to say, hey, I did my best. Hopefully I made society a little bit better, okay? And so that's sort of my story. That's my story of why I'm in academics, right? I love going to work. I love coming home, right? I love the fact that my job is relatively flexible in regards to my clinical work. I could do some administrative, I could do education, and I could do my research. I love it. If you guys have any other questions, please ask. Thanks.
All right, thank you, Dr. Chung. We're going to do our private practice next with Dr. Golding. Dr. Lauren Golding is a pediatrics and women. Good? Okay. Well, I'll invite the whole panel up real fast. We'll do that. So I'll have the whole panel come on up. So here's what we'll do. I will introduce everybody, and then we can kind of really quickly come down. I just want to make sure we have plenty of time for everybody to ask questions. So we have Dr. Lauren Golding. Dr. Golding is a pediatric and women's imaging radiologist at Triad Radiology Associates in Winston-Salem, North Carolina. With our hybrid model, we have Dr. Franklin Moser, the Director of Clinical and Interventional Neuroradiology at Cedars-Sinai Medical Center in LA. Dr. Rohini Nadgir is our teleradiology model. She's an assistant professor at Johns Hopkins Imaging. And then Dr. Reed Omary is going to be our interventional radiology model and chairman at Vanderbilt University in Tennessee. So if if you want to start at one side and move and just kind of give a quick of how you arrived at your model, and we'll go from there.
I first have a question. Why is it that the residents always sit in the back of the room when there are plenty of seats up here?
It's required.
It's required? Okay. All right. I'm at a weird practice. I have to be careful. Several of my residents are sitting in front of me, making sure I'm honest. We're at a very large private hospital that when I first got there 25 years ago was sort of making a transition from being a very big community. They what? You can't hear me. Okay. When I first got there, it was transitioning from a very big community-type hospital that had a few departments that were nationally known to a major medical center. But certain parts of the department of the hospital were still driven strictly by private practice. And so we have an imaging department that includes radiology, nuclear medicine, and nuclear cardiology, which is strictly constructed as a private practice contracted with the hospital to run those services. However, part of those things that we are mandated, and some of us like to do, are run research programs. So you don't have the same time and freedom to do that, and it requires a certain amount of extra effort. But part of the reason why that attracted me was back in the dark ages when I started this, academic radiology had a slightly different reputation. It was the people who said, I want to be an academic radiologist, and then would sit in their rooms and write case series and case reports and get promoted, when the people who did all the work didn't get promoted because they didn't have time to write papers. And we kept saying, well, what's the scientific importance of writing another case series on a new finding with this new machine? The MRI was new in those days when we're doing all the work. And so a large number of us in those days left strict academic practices for these more hybrid type practices. And I think I've survived. Am I doing a good job, guys? Yeah, okay, they're agreeing with me.
Thank you. Dr. Golding.
Hi, so I'm Lauren Golding. I'm the private practice perspective here, but in truth, I'm kind of a double agent because I was in academics for 2 years before moving to private practice. I was on faculty at Wake Forest and then kind of jumped ship to private practice. So I've got a little bit of perspective from both sides. For me, and I think for a lot of people, when you're deciding on your career path, it comes down to two things really, personality and passion. And for me, I'm a pathologically efficient person. And some of the things of academics sort of frustrated me that, was a little bit less efficiency minded. I wanted clean lists. I wanted to get the job done. I wanted to, double reading with the residents sort of, just drove me crazy because this is time that we could be doing things. And certainly there's value to teaching the residents, and I enjoyed that. But for me personally, some of those things were what drove me to private practice. The other thing is, another pathologic character flaw is that I have a passion for health policy. And I put my kids to bed and I go read the 1,200 pages of the QPP because that's what I love doing. And for me, my niche in private practice was it was easier for me to fill that role for my group that I'm in now than it was in a larger academic setting. And I think just finding the place that you can fit in best and have your needs and your career goals met the most are the easiest to do. There's some trade-off for sure. I have 3 daughters. They're 9, 5, and 3. So there's some flexibilities in academics that you don't necessarily have in private practice. We're busy. I mean, we work really hard. And I think in general, the stereotype is that private practice is a bit of a sweatshop. That's not always entirely true, but I would say the volumes, in my experience, are significantly higher in private practice. And it is, you're there at 7:30, you leave at 5:30. If you're a partner and owner in a practice, you may stay till 6 or 7 because this is what you do and you get the work done. It's a little bit different than in academics where there were some days you got done at 2:30 if you're reading screening mammograms and you go home, or you had more people to cover you if a kid gets sick. So there's certainly trade-offs to it. That's something that I've had to really consider, especially as a working mom and dealing with all of that. But I'm happy to answer any questions about private practice or the contrast between the two. Thank you.
Thank you. Go for it.
I'm Rohini Nadgir, and I started off after finishing a neuroradiology fellowship as a full-time academic neuroradiologist at Boston Medical Center. and I worked there for a good 6 years until a new opportunity came along, working as a academic neuroradiologist for Johns Hopkins Hospital, but I do that from my home in Massachusetts. So it's a little bit of an unusual situation. I kind of consider myself an academic teleradiologist, where I feel the best of both worlds. I can enjoy the benefit of doing 100% neuroradiology, which is my passion. I get to teach residents and fellows, also a passion, and I get to do it in my pajamas, which is a passion as well. So I really enjoy my current situation. It's really done wonders for me in the fact that I am a mom of young kids as well, and so I have the opportunity to spend time with them as they grow older, but I get to do what I love, which is teaching trainees and doing academic neuroradiology.
Thank you. Dr. Omary.
So my name is Reed Omary. I'm an interventional radiologist, and I'm the chair of radiology now at Vanderbilt. And it's really interesting hearing all of your perspectives. And I think I'd emphasize two things that are really meant to reduce anxiety, because there may be some anxiety about what the future is like. The first thing is that every single person in this room is here because you want to make a difference. And there is no single model that is ultimately the best model. And so we just need to have the respect for one another and to support one another and recognize that we are a giant radiology community that is really about helping us all be collectively successful and benefiting patients. And you can do that in so many different ways. So I think that's the first thing. So no matter what you choose, you'll be doing the right thing for you at that time. The second thing is when you're trying to decide what to choose, we heard different ways of hearing this, whether it's the personalities or the pajamas. You know, I might look at that as culture and decide which culture you fit in. And you know, that's often what I'll recommend to medical students when you're trying to decide which specialty to go in. If you've got two specialties and they both are interesting to you, choose the one based on the culture. And the same thing is then when you're done with your training, you're not sure, just decide, is it an academic culture? Is it a hybrid? And you kind of know yourself. Do you want to be someone that works more alone, or do you want to be someone where you really like the hustle bustle and make your initial decisions there? No matter what decision you make, there's no cul-de-sac. It never ends. There's no single decision you'll make in the next coming years that will end. You'll be stuck there. You can always jump out, take risks, do what feels right in your heart, and don't ever do these people tell you the checklist, the plus on this side, decision A, the minus here. If you're at that level, neither of those seem to be good decisions. Okay, you just it should just be readily apparent. Anyway, thank you.
That's a very important point. That's a very important point. They tell you what he was saying. Don't do a checklist of goods and bad. Figure out what you're going to have the most fun at doing for the next 30, 40 years. How long? I finished my residency 32 years ago. So I was once the kid. But you have to think about what kind of practice you want to be in that accomplishes, it's not just fun, it accomplishes for you most of the things that you want to do. Of course, you're not going to take a job that pays nothing because you're going to have more, some other great thing. You need to have a balance. You're not going to take an academic job if you have no interest in doing research and writing papers, because that's the only job available. But you have to think that there are a whole series of different kinds of positions available, and more now than there used to be. Can I go to work in my pajamas?
So there are 2 microphones, one on each aisle here. If you have questions, please step up to the microphone. This is meant to be a truly open session. I will start us off real fast. Some of you alluded to changing practice models in the middle of your career. Maybe you could speak a little bit to that, and is it easier to go one direction than the other, you think, or something like that?
I started off in what were strictly academic practices, but going from there into the hybrid situation, was no big deal because we were doing the same thing in those days.
Right.
You know, there was no difference in the work you did.
Right.
There was less reward for doing research work from a standpoint of getting time off and writing the paper, but it was the same work.
Mm-hmm.
I'd say that it's significantly harder to go from academics to private practice if you've been doing that for a long time. Generally in academics, you're in your subspecialty. You don't necessarily read outside of that subspecialty. If you're going to a private practice job where you're reading general things, it could have been 10 years since you looked at a brain MRI, and suddenly you're on call doing that. I was in academics for a little over 2 years, pretty much just doing breast and peds, and then went to a private practice where I'm a partner taking call on the weekends, reading everything. And because it was a short period of time, it mostly just came back. But I absolutely could see if I had been doing that for 10 years, it would be a much more difficult transition. Also, you got to get used to what you're doing. If you're used to the pace of academics, you're used to what's going on there, and you jump over. I think it's probably easier to go the other way around. I think in general, that's what people do. Our group did just hire a neuroradiologist that had been in private practice in academics for, I think he was there for 10 or 12 years, and he's just joined our practice, and he's doing okay. So it can go either way. Certainly it can change. There's things to consider when you move group. I moved groups, but in the same area, so I had a non-compete clause that I had to deal with my academic center. So there's issues with moving, but in general, I think the progression is easier if you go from private practice back to academics.
Any questions out there? Not yet. We've seen a rise in the number of hybrid practices over the last couple of years, and it seems like that trend is continuing as medical systems eat up smaller. How do you think that's going to affect our need to make these choices?
Asking me again? I actually think it makes it easier. The hybrid practice done properly recognizes the need for teaching and research there's work. You're going to keep doing the work. These guys know the hours I put in, the number of scans we read, and the number of procedures we do, but still we make time, and it's recognized that you have to make time for doing the other things, for the teaching and for the research. So the more hybrid practices, I think it'll actually make life easier for a lot of people.
Any comments? Anybody else? Dr. Omary, when you were, do you think that the division of private practice interventional radiologists and academic interventional radiologists is going to change with respect to the fact that private practice people tend to do kind of 50-50, or they do partial diagnostic and partial interventional?
So I think we're going to have a couple of really seismic changes. So one is I predict certainly within 10 years, everyone in this room is either going to be working on one hand in academics, or in another hand you're going to essentially be an employee, just like what happened with the cardiology model. You're going to be an employee for a company that is traded on the New York Stock Exchange. Okay, so that's I may be completely wrong, but
I feel like we're already seeing that a little bit now.
So there can be really large private groups that we're seeing that are being bought out, and essentially it's either going to be owned by private equity, or they're going to. So you're basically, as a radiologist, reporting to shareholders. So that's So actually, I think what is going to be the bigger difference. So that will be the bigger difference. I think interventional radiologists there'll be more similarities between the interventionalists in academics and the ones that are working in these as employees, and they'll tend to have very separate packages.
Right. Thank you. Microphone here, yeah.
Sure. Hi, my name's Jason Hartman. I'm from University of Washington. Go Huskies. And I'm actually our RSNA resident representative from that program. And the rumors that we hear are that the volumes are generally going up at academic centers, and that salaries are becoming closer together. Do you think that the jobs of academic versus private practice hybrid model, these will become more similar over time, or what future trends do you guys predict?
Dr. Chung, do you want to start us out there?
I'm not a money person. Never been motivated like primarily by money, right? But it seems like most of the money in radiology is generated by RVUs, by reading studies, right? I think most people would agree with that. And so it seems like the more RVUs you generate, probably the more money is available to be distributed to the team members of your organization, right? So I think from just a practical standpoint, that's the case. That being said, we are moving toward more of a quality model. So what that actually turns into, I'm not quite sure. I don't know what happens with MACRA. I don't know what happens with MIPS, right? And if you guys don't know what I'm talking about, you better read up on it because it's coming, right? MACRA, MIPS, right? Who here does not know what I'm talking about? Everyone at least have heard those terms. Okay, good. So this is in flux. We'll see how things work out. But you know what? Don't be motivated by money, okay? Don't. Be motivated by, because all of your waking hour, or the majority of waking hours are at work now, right? Until you retire. And so how sad is it if you go to work and you actually don't like your work, but you make a crap load of money, right? That's sad. That is so sad, right? You want to go to work where you're like excited to go to work, right? And if you make, a couple bucks less, who really cares? Is it going to affect your ability to send your kids to school? No. Going to affect your ability to retire? No, unless you're silly with your money, right? Buying like Lamborghinis left and right, stupid stuff like that, which I'm sure all you guys don't do, right? Yeah, or start buying Bitcoins. Don't buy Bitcoins. Bad investment. Yeah, that's true. Yeah, if you bought it about 5 or 6 years ago, yeah, exactly. So bottom line is, I don't know what's happened with money, but that shouldn't be your primary motivator. Yeah.
Part of, I think, what you're referring to is what I call the radiology treadmill, where you work really hard, produce more RVUs, the government responds and the CMS responds by cutting the reimbursements, so you work harder to keep up, and then they cut the reimbursements again, and so you work harder to keep up again. And there comes to a point where you can't work any harder. we seem not to get there yet. We don't know how long that we can continue doing this. Yes, the statistics show that radiology incomes have remained stable or have gone up slightly over the years. But I remember the days when guys I knew in 1988 were getting $2,000 for reading an MRI. And now we're getting, $75. How much? What's the Medicare reimbursement for an MRI, non-contrast MRI? So yes, it's going to be a problem. Yes, if we wanted to earn money, we should have all gone to business school right out of college. But you won't starve. You may not. Right. You're still going to do better than your friends who didn't go into radiology residency. Yeah, and I think things are going to even out. Yeah.
Great. Any other questions from out here?
Thanks to all the panelists.
Any questions? Dr. Nadgir, do you still find that in a teleradiology practice you're able to get the interaction and consultation and whatnot that we find in both academics and private practice?
So I have to say that working remotely has its advantages, but it does have its disadvantages, where there is certainly a disconnect. I don't know my clinicians face to face. I often don't know my trainees face to face, and so that's where the phone comes in really handy. Right. And so I do try to make an effort personally to reach out to trainees, clinicians, and the like, just to maintain that relationship, because there is a certain disconnect with not being on site. So I think that's sort of like on me to make that relationship work.
Yeah, go for it.
Hi, my name is Giuseppe Toya, also from the University of Washington. I had a question more pointed for proceduralist and interventional radiology, but with the advent of the DR-IR residency and a focus on clinical care, what changes do you foresee that need to be made for the private practice model?
I missed your question, the very last part of it. Can you repeat?
Sure. Just with the advent of the DR-IR residency and the focus on clinical care surrounding seeing patients in clinic, what type of changes need to be adapted in the private practice model to make that work?
So it's a great question, and if you take a bunch of interventionalists in private practice and you get them liquored up, you may get a better understanding of the truth. And the truth in many private practices is that the interventionalists feel that they're an island amongst an ocean of diagnostic radiologists. And much of the, it varies from openly stated to unconscious bias to whatever you want to call it, that the DR members of the group don't get us. And they don't give us the time to round, they don't give us the time to go see patients and all of that. With the new residency program, it essentially places a stake in the ground and says that, you know, this is a future. Do you as a DR group want to buy into it? The problem really may go away because private DR groups are no longer going to be managed as private DR groups. The DR radiologists will be employees for a large corporation. And so it really comes to, all right, if you want to grow the IR practice, you grow it and you're on your own. And that's actually what I think a number of IRs actually will really enjoy that model.
There's a practice, this is already happening. There are some places where the IR groups are setting up independent practices and contracting with multiple small hospitals to run the IR for those hospitals, and in most places they have some large radiology, company doing the diagnostic stuff, and they're perfectly willing to let some other group come in and do just the IR. The problem you're going to run into with that is, again, once you're running your own business and you're working, you're getting paid for the procedure, you don't have the fallback of, well, if I'm not doing a procedure, I can then go and read 400 chest x-rays to make up for the income from my downtime. That's the danger. And so you have to have a sufficient volume to run it.
How many people in the audience are either going into IR or doing just so I get just raise your hands. Okay, so I want to be really concrete. The competition is not DR, okay? And all of the stuff that you're going to learn in IR with a clinical practice is really, really critical. That will not distinguish you from the competition. The competition are surgeons, cardiologists, nephrologists, etc. What will distinguish you from the competition is your imaging background, your DR training. You have to embrace the DR training, and you have to have all of those links to DR. The competitive advantage for IR is DR. Just wanted to emphasize that.
Sure. Microphone back there.
Hi, I'm Yasser.
Speak up just a little bit if you could.
Hi, I'm Yasser, resident representative from Leahy Hospital in Burlington. So with the current hype that we are seeing in AI and machine learning and everything, I think it would be unfair not to ask about what your predictions are, the impact it's going on to have on resident training in future and also the job market.
You can't do AI. Procedure can't be done by AI. The AI thing is a little weird because it's still a few years away. So right now, all the AI companies are demonstrating to us that they can read non-contrast head CTs from the emergency room, which we don't need help for that. The danger is that they will figure out how to do that, and so the reimbursement people, instead of reimbursing the same amount for a non-contrast head CT to the ER as the complicated case, they'll start giving you $3 for it like it's a chest x-ray because you're having it done by IR. And because what's going on right now, it's the 40 normal head CTs from the emergency room that are paying for your time to spend 2 hours with one complicated case. So this is what the problem is going to be ultimately. How do you balance that?
I want to make sure we get to as many people here. This microphone here.
Hi, Mohammed, University of Michigan. My question is, with regards to private practice, teleradiology, and academics, once you're in a offer position, when you've been given an offer, what kinds of things are negotiable? What are the limits to that relative limits to negotiating in this setting without potentially offending someone? Or do you have to feel like you have to take whatever offer is given to you because, quote, that's what we've give everybody before you?
Well, so from an academic standpoint, I'll tell you that I've never taken an offer. So I've taken 2 jobs, academic jobs, National Jewish and then at University of Chicago, and I've never taken a job without negotiating, right? Because then you're underselling yourself, right? Because you have 2 parties, both parties want what's best for them, right? And so it's very seldom that someone is going to give you a job offer, especially coming straight out of training, where they're not getting the majority of the win. It's not really a win-win. It's like a big win for them and maybe a small win for you. But you want to kind of equalize the win, right? So it's a win for whoever's hiring you, but also a win for you. And so for me, like the way I see it is, especially for academics, it's pretty easy. So for me, I take a step back and think, what do I need to be successful as an academician, right? To do research, do education. And that really boils down to time, right? Academic time to get stuff done, right? So I don't have to do it like at home while my 3-year-old is begging me to play with her. That's sad, right? You don't want to do that. Don't do things that make you sad, right? That would make me sad. So number 1, time, and then the other thing, like grants, right? So like an internal grant, get me started, some sort of startup grant, so I can start my research, and then from there I have the data to actually get bigger grants. And so those are the things I always ask for. Those are the things I've always gotten. Well, always, twice. N of 2, right? Yeah, but bottom line is I don't think anyone would balk at that. That is not, I think, offensive to anyone. If you say, hey, look what I've done during my residency. Clearly this demonstrates that I want to do academics. I really want to have a steep inflection of my career path and really really start doing good stuff. And to be successful, I need that. What I wouldn't ask for necessarily is more vacation. That does not help you become a better academician, right? That just shows that you want more vacation, right? And so that's not what I would go for. I would, from an academic job, I would ask for academic things. Could you ask for more pay? Yeah, and I have, right? I've asked for more pay, I've gotten more pay, right? And I don't think that asking for more pay is offensive at any level, unless you're asking for something ridiculous.
Dr. Golding, what do you think about private practice with respect to that?
Well, I think from a contract standpoint, if you're joining a private practice of, my group's 45 people, I'm not going to come in as a new person with, same level of training as other people who have been recently hired and suddenly negotiate $100,000 more in income. I'm just not, that's not going to happen. They're not going to set that precedent of wavering those kind of things per person. It's not smart business for the practice. It doesn't set a good precedent. If it's something that matters to you or something, that is really important to you, then certainly bring it up. I think in the end, if there's a bunch of things in that contract that you don't like, that's probably not the group for you, right? If they have certain stipulations that you can't live with and work with, then instead of trying to talk them into extra time off or extra vacation, then maybe consider different groups. My group is a little bit unique in that we have this variable compensation plan where essentially you say how many weeks you want off and your salary is prorated according to that. So we have people who take 7 weeks off a year, we have people who take 17 weeks off a year, and then they're compensated accordingly. Their weekends are according. So we have a lot of flexibility in that, and that's one of the bonuses of my private practice. I think every practice is different. Every practice's response to negotiation is going to be different, and part of that's the attitude that you present it with when you're sitting down with the person who's hiring you. It just depends on how you come across as entitled and this is what I want, or these are things that are important to me, this is why, and then it's more of a discussion. I do think it's rare to just come in and make demands and have those met, and then you're working with these people, right? So you certainly want to preserve a relationship of collegiality.
We are
there too.
unfortunately out of time, and
Okay,
so I encourage.
Let me just say one thing
sure, of
real
course.
fast. Okay, so I took a 6-month class in negotiations when I went to business school. I graduated 10 years ago, so you're not going to learn negotiation skills in one afternoon. The problem is doctors gave up, the radiologists especially, gave up the business aspects of our field for the most part when MRIs became too expensive for us to just shell out money and buy them. So which is why we're having companies that are going to end up hiring all the radiologists and them owning all the equipment ultimately. So all of you should go and learn a little bit about practice management, negotiation skills, leadership skills, all these things that we all avoided because we did science and we went to medical school. And it's very hard to learn them, but you have to.
Thank you all very much for coming. I encourage you to take advantage of your RSNA week to talk with people in the hallways when you see them, introduce yourself, and ask them these questions.